Okay, good evening everyone. So today's class is on anemia in pregnancy. Okay, so first we'll learn some introduction. So almost 50% of Indian females are anemic. Okay, so half of the global deaths in pregnancy is due to anemia. Okay, and 80% of morbidities in females in Asian subcontinent is in India. In this 80% of morbidities, almost 50% is due to anemia. Okay, so now we learn about definition. So according to CDC, hemoglobin, if it is less than 11 gram in first trimester and third trimester, is known as anemia, and hemoglobin less than 10.5 gram in second trimester is known as anemia. According to WHO and ICMR, okay, hemoglobin less than 11 gram is anemia. Okay, now let's learn about types of anemia. There are 4 types: mild, moderate, severe, and very severe. So mild is 10 to 10.9, moderate is 7 to 9.9, severe is less than 7, whereas very severe is less than 4. Now let's learn about some physiological changes in pregnancy. So in pregnancy, the RBC mass increases, the plasma volume increases. So remember one easy thing: when a girl becomes pregnant, she loses her concentration. This is a mnemonic to easy remembrance. Okay, so the hemoglobin concentration decreases. The RBC concentration decreases. So the oxygen carrying capacity decreases in pregnancy. Okay, so this is important thing. Coming to what is the iron requirement is, generally it is about 1000 milligram per day. In this, 500 milligram of iron is involved in hemoglobin formation. Almost 300 milligram is going to fetus. Almost 200 milligram is lost in urine, feces, and sweat. Okay, so averagely the daily requirement of iron is 6 milligram per day during pregnancy. So in first trimester is about 0.8 milligram per day, whereas this requirement becomes in third trimester 7.5 milligram per day. So an average Indian diet provides about 5 milligram per day. Okay. Next, iron is transferred to the fetus by means of active transport to gradient. Okay, so effect of anemia in pregnancy. So what is the effect? First, antenatally there is a risk of infection. There is risk of infections. There is risk of preterm labor. There is risk of pre-prom. There is risk of preeclampsia, and there is risk of antepartum hemorrhage. Coming to intrapartum effect of anemia is, there is uterine inertia. Okay, there is maternal exhaustion because of weakness and all, maternal exhaustion. Okay, even in intrapartum there is high risk of bleeding during anemia. Coming to postpartum, there is risk of BPH, there is risk of sepsis, there is risk of VT, there is risk of postpartum depression, there is healing difficulties, healing difficulty, cardiac failure. Okay, even antenatally also there is cardiac failure risk, mainly at 28 to 32 weeks gestation. Okay, PPH, sepsis, VT, postpartum depression, uterine subinvolution. Okay, uterine subinvolution. These are the effects of anemia. Now coming to effects of anemia on the fetus. Fetus will become low birth weight, almost two-folds there is increase in low birth weight. There is a risk of anemia in the fetus, neonatal anemia is called. So there is neonatal anemia risk of 6 folds, and infections in the fetus, and there is placentomegaly in the fetus, while fetus in the womb. Okay, so coming to classification of anemias. So first, anemia is classified as 2 types. Okay, so if there are acquired anemias, there are inherited anemias. Okay, so coming to acquired anemias, first important thing is nutritional anemia. There is some reason of nutrition. Then there is hemorrhagic anemia. Then there is anemia of chronic disease. Anemia of chronic disease is one of the anemia. And you have aplastic anemia. Okay, aplastic anemia. And there is acquired hemolytic anemia. Acquired hemolytic anemia. Coming to inherited you have thalassemia. There is sickle cell anemia. There is inherited hemolytic anemia. Inherited hemolytic anemia, other any hemoglobinopathies. Okay. So how to approach a case, approach a lady, a pregnant female who comes with anemia, how to approach it? First you classify the classification of anemia. We'll see the clinical and lab evaluation. We'll know the cause. We'll find out what is the cause of anemia. Okay, so first we'll type the anemias. Then this clinical and lab evaluation, and we'll find out the cause. Okay. So coming to history will ask about any history of weakness, lethargy, lightheadedness, any history of palpitations, breathlessness, orthopnea, chest pain, okay, any skin and nail changes, okay, edema, any worms in the stool, okay, any history of hyperemesis gravidarum, any history of chronic disease, okay, any past obstetric history, have blood transfusion, IV iron, okay, any history of pica, okay, what is a socio-economic status, because some anemias hail from some part of country. This is about history. Coming to physical examination, it's running right, yeah. Okay, physical examination, from top to bottom we'll see. From top to bottom we'll see the patient. So first thing is pallor, then we'll see the nails. First thing is pallor, then we'll see the nails, cholionychia, platynychia, okay, and there is any glossitis, any chelosis. If there is any JVP raised like more than 8 centimeter of water, which is seen in case of congestive cardiac failure. Next about jaundice, edema, lymph node examination. Okay, this is this thing. Coming to lab tests, generally we'll do hemoglobin of 4 visits. Like WHO says that minimum 4 visits in AMC. So all the minimum 4 visits we'll do the hemoglobin test. Only hemoglobin. And Williams or ACOG says that 2 hemoglobin tests are required. One on the booking visit, other on the at 28 weeks. Okay. If the hemoglobin is less than 11 gram, then we'll do the other indices like CBC and these indices RBC like MCH, MCHC, MCV. Okay, and this reticulocyte count, hemoglobin electrophoresis. If you feel that this patient has sickle cell anemia, then you will do hemoglobin electrophoresis. Yeah, in this jaundice, edema, even leg ulcers can be examined, mainly to see in case of sickle cell anemia. Okay. So next is Menger's index. So Menger's index is MCV by RBC count. Okay. So MCV is in femtoliters. For example, 60 femtoliters by RBC count is 4 million by microliter. So it is around 15. Okay. So if this Menger's index, if it is more than 13, then it is in case of iron deficiency anemia. It is in iron deficiency anemia. Whereas if it is less than 13, then it is in case of thalassemia. Okay. So Menger's index iron deficiency anemia, it's also seen in anemia of chronic disease. Okay. So first we'll learn about what is MCV. MCV is mean corpuscular volume. Generally, it is 75 to 100 femtoliters. Okay. If it is MCV, if it is less than 75, it is generally seen in case of anemia, iron deficiency anemia, anemia of chronic disease. That way. Okay. If MCV is more than 100, it is seen in case of macrocytic anemia. It can be because of folic acid deficiency or vitamin B12 deficiency. This is also seen in case of hypothyroidism. Also seen in case of liver disease. Okay. That's about MCV. Next we'll learn about very most sensitive RBC index. Okay, indices in indices most sensitive is MCHC. Generally the value is 30 to 34%. If it is less than 30, it is in case of iron deficiency anemia. Okay. If it is less than 30, it is in case of iron deficiency anemia. Now we'll learn about so iron deficiency anemia stages. Iron deficiency anemia is of three stages: stage 1, stage 2, and stage 3. Stage 1 is the stores are getting depleted. Okay, here the hemoglobin is normal. In stage 2, the TIBC increases, the transferrin saturation decreases, serum ferritin levels start decreasing. Here also hemoglobin is normal. Here the thing is normocytic anemia. In stage 3 is hemoglobin gets decreases, so we'll have a microcytic anemia. Okay. So coming to serum ferritin levels, generally the serum ferritin levels are 20 to 200. Okay. If it is less than, it should be more than 100 for good anemia. For anemia, if it is less than 100, the person can land nearly to anemia, but it should be generally normal. For normal hemoglobin to maintain, it should be more than 100. Okay. So next is iron deficiency anemia stage 3. You will have serum ferritin levels of less than 10. Okay, serum ferritin levels of less than 10. So if you see serum iron levels, generally if it is less than 40, then it is in case of iron deficiency anemia. And serum TIBC levels, if it is less than 410, it is in iron deficiency anemia. Nearly if you think 400. Okay, I remember that it is a 40 iron RD So 40 years of iron auntie. So iron, if it is 40, it is in iron deficiency anemia. And second thing is TIBC certificate. To get this certificate, we need to pay 410 rupees. So TIBC is less than 410 is in case of iron deficiency anemia. So coming to serum iron, okay, by TIBC it is 440 by 400, it's almost 25%. So this is generally the transfer in saturation, okay, transfer in saturation. Again, this transfer in saturation, if it is less than 10, it is in case of iron deficiency anemia. So ferritin is less than 10 and transfer in saturation is less than 10 is iron deficiency anemia. Serum iron is less than 40 and serum TIBC is less than 410 is iron deficiency anemia. Okay. Other things like serum hepcidin. Serum hepcidin is generally increases in case of iron deficiency anemia, whereas it decreases in case of anemia of chronic disease. Okay. Other markers like FEP, that is ferric erythropoietin, ferric erythrocyte, protoporphyrin. Okay. This is generally a precursor of heme synthesis. Okay, heme synthesis. So in iron deficiency anemia, this ferric erythrocyte protoporphyrin increases. Okay, that is one of the marker. Another thing is serum soluble transferrin receptor. Okay, serum soluble transferrin ferric receptor or something. Okay, this also increases in iron deficiency anemia. And that is zinc protoporphyrin receptors increase in iron deficiency anemia. Okay. For anemia of chronic disease, or else not really chronic disease, and for anemia, refractory anemia. Okay, for refractory anemia, the most sensitive marker is bone marrow staining of iron. This is a gold standard diagnosis of refractory anemia. Staining of bone marrow is not seen. Okay. So next is prophylaxis of iron deficiency anemia. So in this there is a program known as Anemia Mukt Bharat program. This program came in 2018. So it based on NIPI. Okay, that is integrated National Iron Plus Initiative. Okay, so in this there is a strategy, a 6x6x6 strategy, in which there are 6 beneficiaries. So first beneficiary is 6 months to 59 months. Take this 59 months. So 5 years to 9 years. Take this 9, 10 to 19 years. Okay, then women with reproductive age group, then you have pregnant women, then you have lactating women. These are, okay, this is an easy way to remember the age. 6 months to 59 months, then 5 to 9 years, then 10 to 19 years. Next is 6 interventions. Okay, 6 interventions is, first you will do a digital hemoglobinometers to be supplied to measure the hemoglobin. Then we'll give iron tablets, iron folic acid tablets. Okay, then deworming is done. Okay, deworming is done. Okay, next food should be fortified with iron, fortified food. Okay, and you'll find the other causes. We should do delayed cord clamping should be done, and other causes should be found out, like any hemoglobinopathies and all we should find out. Next, 666 institutions. Okay, in 6 institutions it comes under administrative block. Okay, that's about 6x6 initiative. And coming to iron folic acid tablets, generally in case of anemia prevention prophylaxis, iron folic acid tablet is given, in which iron is about 60 mg elemental iron and folic acid is 500 mg of folic acid. But if any woman is trying for pregnancy, then trying to conceive, then you'll give 400 micrograms of folic acid. Once she gets pregnant, then let her continue this 400 micrograms of folic acid in the first trimester. Okay, so after first trimester, we'll give the iron folic acid tablet, which she will take for 180 days during antenatal care, and plus 180 days in postpartum period also. Okay, this is the main content. Next is iron tablet. Generally the iron tablet is given in the empty stomach, okay, or else if you're taking you took food, then at least after 2 hours of intake of food you should not take a given iron tablet. Okay. So that's about iron tablet. Generally, if we take iron folic acid for more than 4 weeks, then there is 0.7 gram increase in hemoglobin. Okay, so you should measure the hemoglobin after 4 weeks, and if it is not increasing, that means there is non-compalient. Okay, they are non-compalient, or it's not suitable in that way. Okay, so if hemoglobin is less than 11 gram or less than 8 gram or something like that, for example, if hemoglobin is 8 gram in 26 weeks, then we'll give double dose of iron. If hemoglobin is 8 gram in 32 weeks, then we'll give iron injection. That is a concept. Okay, so basically if it is a third trimester, we should go for iron injection because there is immediate risk of blood loss. So generally iron is given in the form of ferrous sulfate. Here generally the thing is about 300 milligram it is given, whereas other forms are also there, like ferrous fumarate, which is about 180 milligram. Another is ferrous gluconate. Okay, gluconate, it comes under 500 milligram format. Okay, coming to how to calculate how much amount of iron to be given, that is Ganjoni's formula. So here the thing is 2.4 into hemoglobin deficit into pre-pregnancy weight plus 500. This is the formula. So we'll calculate by using this. If the female is obese, like if she is 90 kg, okay, then we should not keep 90 here. Okay, generally we should give according to height. What is the thing we'll measure? We'll keep an ideal weight and we'll give. If this female is less than 35 kg, we should not keep 35 kgs here, then the amount will be coming less. So for this woman, we'll give 15 milligram per kg body weight. Okay, and generally we use ferrous sulfate. I think generally it is it is in a 5 ml one, where it is 20 milligram per ml. So 5 ml one, so it is 100 milligram in ampere. Okay, so we'll give this in 200 ml NS, and first initial 5 minutes we'll give slow, that is 80 drops per minute. Okay, sure, 80 drops per minute. Yeah, later in 20 to 30 minutes we'll complete the thing. And one more thing is there, that is which is absolute one, that is jet technique is used to give iron injection, but this is absolute now. Okay, so if there is any reactions, what you'll do, you'll give injection Evel, injection hydrocortisone. Okay, and you can give adrenaline 1:1000 dilution. In this we'll give only 0.5 ml. So before giving IV iron, we should ask about history of any allergies. Okay, and generally the iron helps in increasing the hemoglobin, like within like 0.7 milligram per week it increases. Okay, that's about this thing. Coming to peroxycarboxymaltose, generally one vial it is about 500 milligrams. So if you want to give 1 gram, you should give 2 vials, and we'll keep this in 100 ml NS, and we'll complete it in 15 minutes. Okay, 50 ml NS is flushed before and after the injection. Side effects of FCM injection is headache, nausea, constipation, diarrhea, breathlessness sometimes. Okay, so that's it. Yeah. Okay, by giving iron injection, like hemoglobin start to increase by 1 gram by 2 weeks, and reticulocyte count also increases by 4 weeks. Okay, so what is the need of blood transfusion? Blood transfusion indications in pregnancy is 7. 1. If the hemoglobin is less than 5 gram in any trimester. 2. Hemoglobin is less than 7 gram in third trimester. 3. If there is any features of congestive cardiac failure. 4. If there is hemodynamic instability, like if the BP is less, this thing and all. 5. Acute hemorrhage, like if you have any PPH, rupture uterus and all. 6. Thalassemia major. 7. Bone marrow transplant. These are 7 indications for blood transfusion in pregnancy. Okay, so next is anemia of chronic disease. Anemia of chronic disease. So in this, there are this kind of anemia seen in case of patients with TB, cancer, rheumatoid arthritis. Okay, so features are laboratory features mainly. There is low iron, serum ferritin is normal or raised. Okay, serum hepcidin is raised. Okay, SFTR is decreased. Okay, SFTR is decreased. TIBC is decreased. Okay, these are the features of anemia of chronic disease. So treatment for this anemia of chronic disease will give recombinant human erythropoietin. It comes under 4,000 international units. We'll give 3 times in a week. 3 times in a week for 2 weeks. It's a treatment. Next is megaloblastic anemia. Megaloblastic anemia is a condition where there is because of folate deficiency or vitamin B12 deficiency. Risk factors is this particular woman can have abortions, preterm births, okay, neural tube defects in the fetus, okay. Basically features of megaloblastic anemia is first thing anemia. Second thing, if you see MCV, it is less than 100. Less than 100 on MCV. Okay, then and there is raised LDH. Okay, there is raised LDH. There is raised homocysteine levels. Okay, there is raised homocysteine levels. Generally, we'll give 400 micrograms of folic acid. At least if in a woman should have who's trying to conceive, at least 1 month before pregnancy, she should be taking folic acid. Okay, and megaloblastic anemia. Vitamin B12, if there is any deficiency, then we'll give vitamin B12. 1,000 international units will give. It is also 3 times in a week for 2 weeks. Okay. Baki features are you can see big cells. Okay, even multi-lobe neutrophils can be seen. Okay. So MCV in megaloblastic anemia is more than 100, more than 100. Okay. Coming to next disease is hemoglobinopathies. Okay, hemoglobinopathies. So first thing I'll describe about hemoglobin molecule. Okay, this is the hemoglobin molecule in which there are 4 chains. Okay, alpha 1 chain, alpha 2 chain, beta 1 chain, and beta 2 chain. All these 4 chains, there is center molecule known as Fe2 plus molecule, iron molecule. So this hemoglobin molecule is about 68,000 daltons is the weight. Okay, and it is united by 4 chains and 4 iron molecules. Okay, so this beta chain is very important chain, and alpha chain is generally produced by means of genes present on the chromosome number 16. Okay, so there are totally 4 alpha chains, 2 from the male, 2 from the mother, 2 from the father. If one is absent this way, if one chain is absent, then it is mild anemia. If one chain is absent, nothing. Okay, if 2 chains are absent, then there is mild anemia. If 3 chains are absent, if 3 alpha chains are present, then there is moderate to severe anemia. If all the chains are absent, that is known as hydrops fetalis. Okay, and alpha thalassemia is a very rare disorder. Okay, so generally hemoglobin is most commonly is hemoglobin A, where there is alpha 2 and beta 2 chains. Okay, this is 95%, and some 3% condition there is hemoglobin A2, which is alpha 2 and gamma 2. Okay, and less than 1% cases there is hemoglobin F, which is alpha 2 delta 2. Okay, coming to thalassemia major. Thalassemia major is generally we have 2 beta 2 genes. This beta is from father and this beta is from mother. If anything is absent, then if one is absent, it is known as minor. If both beta chains are absent, that is known as major. Okay, if the mother and father both are minors, then the son, that baby of the couple, have 25% risk of getting thalassemia major. Okay, so next is sickle cell disease. Sickle cell disease is a condition where there is quality of the beta genes is affected. Okay, so beta chains generally are seen on chromosome 11. So in this the genes produce in such a way that the hemoglobin A become hemoglobin S. Okay, here what happens is the valine gene replaces the glutamic acid. Okay, valine gene replaces the glutamic acid, whereas one more condition is the hemoglobin C. Here the lysine gene replaces the glutamic acid. Okay, sometimes there is combination of hemoglobin S plus hemoglobin C as well. Okay, if hemoglobin S is, then that is now sickle cell disease. Sickle cell disease. If it is hemoglobin S, then it is known as sickle cell trait. Okay, so whatever it may be, management is depends upon when you do hemoglobin electrophoresis. Okay, if a female with there is refractory anemia, Menger's index, like if it is less than 13, it can become thalassemia. Then to rule out that, we can go for hemoglobin electrophoresis. So coming to thalassemia major, here generally the iron overload will be there, iron will be more, and mostly if abortion risks are there to this female, and we can chelate the iron by giving desferoxamine. Okay, generally it is given 100 micrograms stat dose and 400 microgram 4 hourly, 8 hourly I think, IV 8 hourly. Okay, and if it is thalassemia minor, then also we'll see, like if mother is also minor, father is also minor, then for them we should go for chorionic wellness sampling at 11 weeks gestation, and we'll test it. Second thing is if the baby becomes thalassemia major, came out thalassemia major, then better go for MTB. Okay, so if mother is thalassemia minor and father is normal, then there is chance of getting baby getting thalassemia minor, 25% chance. If mother is thalassemia major and father is thalassemia minor, then the baby can have a chance of getting 50% of thalassemia major condition. So we should be cautious in this particular situation. Okay. So what are the complications? So complications of this thing is sickle cell anemia is there is a high chance of infection, sepsis, okay, bleeding. Okay, so what are the triggers of sickle cell anemia crisis? Like if there is dehydration, okay, if there is any cold, if there is any hypoxia, okay, if there is any exertion, these are different conditions where sickle cell anemia increases. Some non-pregnant patients are given hydroxyurea. This hydroxyurea makes the hemoglobin F increase in the hemoglobin F. So if there is hemoglobin F instead of hemoglobin A, then sickle cell anemia is generally doesn't occur. But this hydroxyurea has a teratogenic effect. So there are craniofacial defects. So we should stop at least 1 month, at least 3 months, sorry. At least 3 months we should stop this drug and go for pregnancy. Okay. Sickle cell disease, people will have hypertension and they're generally on ACE inhibitors, ARVs. So if they're becoming pregnant, then it needs to be stopped and converted into another antihypertensive. Okay, so if a pregnant female sickle cell disease came into the labor room in labor pains, first thing we'll keep her hydrated, okay, and we'll keep her oxygen propped up position, okay, and we'll find out what is hemoglobin, okay, and in delivery also we can go for vaginal delivery. Cesarean section is only for obstetric indications, okay. At 39 weeks we'll go for induction of labor. If she is not in labor, then in postpartum we can give progesterone only pills is safest. COC pills should be avoided because the risk of thrombosis, okay. That's why these patients in antenatal care will be kept on heparin plus ecosprin as well, okay. And copper T can be given, but there is a risk of infections, so procedure should be in aseptic conditions.